Hello everyone. I am just recording my next lecture just because of the situations that are going on in my house here. So we are going to talk about roles and employment settings. So let me just get this up for us. All right, so we're going to describe the roles of the PT in primary, secondary, and tertiary care, describe the roles of the prevention and health promotion, test and measures in PT, and what is the professional role of PT related to other areas. So I know that we had already talked about that there are some dramatic changes in the field, and there always will be. Our field is always constantly going to be changes just because of how we are responding to our patients and our patients' needs. A few things why it's changing is, one, the aging population. We are continuing to see adults grow, people age. They grow up and they have the necessary need for us to be treating them. The federal legislation entitling children in public schools to health care. So we have the IEPs that are available to us to be treating children in a school setting. Increased public interest in fitness. And I think that we can all sort of think of something that the public is interested fitness-wise. So we have CrossFit. We have yoga, we have, there are all these, right now I can think of Peloton, so all of these things that are coming up in our society that is increasing our interest in the fitness itself can increase injuries. And then actions taken by insurance companies and government to contain rising costs of healthcare. I sometimes don't think that the cost is being appropriately worked on, appropriately being lowered, but, it is what it is. So the role of the physical therapist, that primary role is direct patient care. So they, even though some patients aren't directly in contact with, some PTs aren't directly in contact with all of the patients, the goal remains the same, that our main role here is to be directly in patient care. There is a thing called the Standards of Practice for Physical Therapy. This is approved by House of Delegates in the APTA, and this identifies conditions and performances that are essential for provision of high-quality physical therapy. And it also addresses ethical, administrative, educational needs. And I'm going to bring it up here on my screen so you guys can see it. There it is. So this is what it looks like, the standards of practice. I'm not going to read this all heart to heart. It is in Blackboard so you can see it, but it does go into ethical legal considerations, administration of the physical therapy service. And this can be anywhere from the organizational plan, policies and procedures, administration, staffing, staff development. There's the patient-client model, education, research, and then community responsibility. So all of those are within this practice, and they each hit all the categories. All right, let me bring this up again. So again, the administration of services, this is your mission, your policies and procedures, fiscal management, your provision of services, so your informed consent, initial eval, prognosis, intervention, discharge, POC is plan of care, education, the fact that you are responsible for having your own professional development in the field, research, where that evidence-based practice, we've talked about that's coming back up again, and then your community responsibility. The book talks about a primary, secondary, and tertiary care. So primary care is where the health care delivered by a member of a healthcare system is responsible for majority of health needs of the individual. This is the first person that patient is in contact with. So your primary care physician, PCP, or family doctor. This secondary care is provided by clinicians on a referral basis after the individual receives primary care. A lot of our services will fall under the secondary care. With direct access now, we can be considered primary care, but typically, you're going to find us under a secondary care model. There is a tertiary care, which is provided by specialists frequently that focus on special health conditions. Helps a patient manage long-term, often complex health issues. So this is where you're going to find more of your burn unit patients, neurology, oncology, and cardiology. You can also include cardiac or stroke rehab in this option as well. Tertiary care is a specialty care. Okay. The physical therapist role, they will practice on all 3 levels. There's not one level that they are not practicing in. We try to go for an interprofessional and collaborative approach or a team approach. Who do you think would be included in this team approach? I'm just going to let you think about that for a second. So when we think about it, it's really any other healthcare professional. It can be physicians, nurses, occupational therapists, as far as dentists, social workers, speech language pathologists, and orthotics prosthetists. All of those can be included in our collaborative approach. Anyone that you're working in a hospital with, your transfer team, your medical assistants, your CNAs, LPNs, all of them are all included. Again, it is generally provided on a referral basis, your therapy work, but there is direct access, which is legal in all 50 states at this point. And this is, again, where you can be seen by a physician. This is where you can be seen by a physical therapist without a physician's script. All right, so now on to the team approach. You will constantly be working with other people within your healthcare team. Again, physicians, nurses, OTAs, speech, social workers. You could work with acupuncturists, osteopaths, anyone with alternative medicine, any manual massage therapists. I always like to say that it's not just healthcare workers. You are collaborating with them on the care of your patients, but also you have a whole other aspect of the team where you have your PSS or your patient service specialist, your secretary, your insurance companies, all of these places that you are going to be working closely with to help your patient in the best fashion possible. One thing that we do need to mention is that we always do prevention and wellness. You will always do this for the rest of your time in therapy. Our goal is not just to get our patients better, but to prevent it from happening again and to keep them well. Generally, the public has really been pushing more towards a healthy lifestyle as it is, which helps us, but we need to make sure that everyone is doing it appropriately. We do have an extensive knowledge on how the body works and what we need to do. We are qualified to provide services that prevent or limit dysfunction, and this will help sort of maintain our costs. So with my patients who are workers' comp patients, I like to, not only am I going to get their pain down and make them feel better, but I'm going to make sure that whatever they're doing for their job, they're doing correctly. If they're lifting, I want to make sure that they're using the proper lifting techniques. If they're sitting at a desk, I want to make sure that their ergonomics is set up correctly. So that way my patient isn't getting hurt again. We can screen them. That, again, determines further services are needed, and prevention, making sure that we are no longer setting them up for a failure and that they're going to be safe where they are. There are health promotion programs. Sometimes you'll find that a business is collaborating with a healthcare team, either Select or Dreyer or CPRS. I'm just naming a few more popular ones. But that way they will help prevent an injury. Select had worked with a trunking company that they went there and stretched 2 days a week, and that was something that helped decrease their injury costs and ultimately saved the company money. So it worked for them. We want to prevent injury and disease, which will reduce a healthcare cost, which will increase productivity. The more people you have hurt, the less productivity you're having at that company. So it would be better off for you to have this program. So that way you're decreasing your actual healthcare costs. They can serve, a therapist can serve as a consultant, either with an ergonomic evaluation. And ergonomic is if you're set up correctly at at your desk, or it can be at your station at work. There are FCEs, which is a functional capacity evaluation. A functional capacity evaluation is a very long test to literally test you from head to toe on your strength and endurance to see what you're actually capable of. You can do this before you get a job. You could also do this after you're injured before you return to a job to make sure that you are actually functioning correctly. There are also work conditioning and work hardening programs. Work conditioning is focusing on the physical dysfunction, and work hardening is physical dysfunction, behavioral, and vocational management. This is where you're going to find your workers' comp patient gets injured, and before returning to work, they go into a work conditioning program where they do things simulating their job for 3 to 4 hours a day, and they come every single day. It's a pretty intense program for your patients, but it does really help them return to work. There's a patient-client management model. This is key. This presents 5 components of gathering information and designing and implementing of a plan of care, POC. Before initiating the services, you must obtain informed consent, which is usually signed at the beginning before walking into the clinic, that they understand they are going to be treated and that the patient is okay with it. Informed consent does propose an intervention, expected benefits and known risks, comparison of benefits and risks with and without the intervention, and alternative treatments. So, for example, if I were to be doing an ultrasound, I'm going to let my patient know that I'm going to do the ultrasound, that with this ultrasound, I expect there to be a decrease of inflammation. There is a risk of being burnt by the ultrasound, but it's a very low risk. By doing this, these are the benefits that I'm going to see. And without these interventions, this is where we're going to be. I'm literally giving the whole story for my patient so the patient can give me consent on to do the treatment or not. So let's take just a look back at the physical therapist's decision making. So I want you to understand that on this slide, the physical therapist has different routes to go. They don't always retain the patient. Obviously, that is our goal, but there might be other options for your patient, either to refer them, to consult with someone else, or co-manage with other disciplines. So when a physical therapist is actually taking that patient for an evaluation, they are thinking of other options. So if we choose to retain the patient, the physical therapist here will develop a plan of care, define boundaries with the patient within what's happening, and always has the option to perform elements of direct supervision. They can also defer it to a PT or PT aide. You can co-manage your patient with psychology, social work, nursing, or you can refer out or consult with someone else. So there are other options for your patient to be set with other than just retaining them at your clinic. These are the elements of the patient-client management model. You will need to know these, so I would put a big old star on this slide. So it starts with examination, evaluation, diagnosis, prognosis, intervention, and outcomes. And we're going to talk about each one in a few slides. So again, this is also another option of how to look at it. You initially have this examination, which will turn into the evaluation. At this point, you will either refer and consult or retain the patient, where you will become a diagnosis and prognosis for your patient. You'll perform the intervention, and you will review the outcomes for that patient. Those outcomes is where data collected and analyzed to create reports to improve services. I'm sure some of you, if you are working in a clinic, have seen them. Examination is gathering history of past and current status, systems review, tested measures. Evaluation is defined as a judgment based on assessment or measurement. So you are first doing this examination, gathering all the information, doing your test and measures. Your evaluation is a judgment based on what you have found from that examination. The PT will then do a diagnosis, which might differ from other doctors. Typically, because we're not treating a broken bone, we treat the pain, stiffness, and weakness because of the broken bone. So your diagnosis might look a little bit different. but it is described as categorization of the findings from the exam through a defined process. A prognosis is a prediction of how you think your patient is going to do, how long it's going to take you to reach that goal in the plan of care that the PT has listed. An intervention, a PT and PTA conduct procedures with the patient to achieve your desired outcome. So I want my patient to have increased stability for the ankle. What am I going to do? Heel raises, single leg stance, ball toss on the trampoline, walking on a balance beam, walking on an unstable surface. There are lots of interventions that you can do. I could go on for days on interventions. And outcomes are a result of the interventions and the entire plan of care. How does the patient feel that they are doing from this point forward? So when we are talking about what we're doing with our patients, you have communication and documentation. Both of these can be written and verbal. This ensures that all personnel are working on the same page, and we're always talking about what we're doing and how our patient is responding. Your written is a permanent record. You will always have it up until, I believe it's 10 years until it can be deleted. It must be clear, concise, and accurate. You cannot lie. It is a legal document. It can be brought into court, so it's important that you are accurate in your information that you are documenting. It is required to document. You will do a documentation, a SOAP note on every single patient that walks into your clinic each and every day. And you will also write a note if they cancel, no show, or have just a communication record. SOAP note is the most common, but there are other ways of documented. There is a problem-oriented medical record where you have, instead of just the diagnosis, you have each problem listed and then you write a SOAP note from that. You will not see that, and we'll talk more about that when we get to our documentation information later in the term. So communication with your patient. It can also be with the family or caregiver or whoever is in direct contact with the patient. You're going to give them instruction on the plan of care, instruction on their home programs, give them visual aids, demonstrations. I can't tell you how many times I've jumped up on a table to show my patient exercise just so they could understand it a little bit better. You're going to communicate their direct interventions, either therapeutic interactions. You're going to show them manual techniques, explain equipment, do an exercise, tell them what the exercise is doing. You're constantly communicating with your patient, and it's extremely important that you are doing this professionally and appropriately. You will also have periodic reexaminations, or reevals as some people may call it, to determine, is what you're doing really helping? That's important. If what we're doing isn't helping, we need to know so we can change our course of treatment. How often do you think you'll do a reeval? Typically, it is every 30 days or every 6 visits. Workers' comp, I know, likes every 6 visits and every 10 visits for Medicare. And then you're going to start discharging your patient when your goals or outcomes are achieved. If the patient is no longer benefiting, then it's not medically necessary, and financially, you shouldn't be continuing. So direct interventions. On page 33 of your book, you're going to find a list of, let me turn there, a list of intervention categories used in physical therapy. Right here is just a small few. So you have your airway clearance techniques, assistive technology prescriptions, biophysical agents, which is thermal, acoustic, electrical, and radiant energy, functional training and self-care, integument repair and protective techniques. That's improving of wound healing. Manual therapy techniques, motor functioning, therapeutic exercise. These are all listed as things that you can do with your patient. Again, on page 33, you will see the intervention and a description of those interventions that you can actually run through and review if there's ones that you don't understand. So there are other professional roles. There is a consultation role, whether patient-centered or client-centered. A patient is basically, it's an examination without interventions, and a client can be expert advice provided by a PT for court testimony or ergonomic suggestions, academic program evaluations, and healthcare policies. So there are other things that you can do in this role without having to treat patients. you do have to go through the program requirements, which is treating first, but there are other professional roles that you could play. There's also education. Again, you're going to educating the patient and the family. You can educate students on internship, academic education, and continuing education. So you could teach a course like I do, or continuing education is basically courses, quick weekend courses is usually how long they last, educating on total knee replacements or specific intervention like Graston techniques or instrument assisted massage, those kind of things that you would be professionally educating other professionals on. You could do a research component. Again, our class is based on evidence-based practice. This validates your intervention used by the PT. I have always wanted to research, but I had never really didn't find the time to do it. And where I worked was not a good clinic for that. And there's also administrative things that you can do, planning, communicating, delegating, or case managers also. So again, there are other things that you could be doing with your degree other than just treating a patient. The next few slides we're going to talk about are mostly just stats. You do not need to memorize these stats, but I did find it interesting to know how sort of the job market looks. It is constantly changing. The need for PT services has diminished, but reimbursement, the need for us has not diminished, but reimbursement has. So they have changed the reimbursement stats for all of us. The most recent data I found was February of 2019. I'll have to look and see how much that has changed since. But the age for PTAs typically is 20 to 29. There's about 18%. 30 to 30, the age 30 to 39, there's about 24.2%. 40 to 50, 25%, and then 50 plus, there's about 31% of PTAs. There's about 128,700 PTAs, and the average mean salary is about $45,000 with 0 to 3 years of experience. It is still a female-driven field where females is 78.3% and males is 21.7%. Typically with the PTs, the highest degree earned is bachelorette 19%, doctorate 44, master's 28. You're going to find that this doctoral number is going to increase with time because that's what's required now. For PTAs, most of us, about over half, have an associate's degree, 34% have a bachelor's, and 1.3% have a master's. I have not met in my field yet someone with a master's degree, so as a PTA, so that is a small portion. When we are talking about a facility of employment, this is where you're going to find most of your employment opportunities. A private practice outpatient is your highest one that you're going to find. That's 33%. Your health system outpatient, so this is like Pinnacle outpatient, that's 20%. Your acute care hospital, 11%. Academic institution, so Central Penn, that's 10%. Home health, SNF, inpatient, school, and other are below 10%. All of which are great places to work. And you see here, there are lots of different options for you in this field. PTA students, again, it is female driven with 7,054 male, and the median age for a PTA student is about 29. The number of students with a previous bachelorette is 2,766, and then the number of students with a previous master's degree is 208. So that is all I have for you guys for this chapter. I will see you in class then, and we will talk further on the library assignment that I have listed for you guys. Thank you. Bye.